Good evening, everyone. Welcome to this yet another Clinix Health Group webinar. We're just waiting for people in the lobby to come in as they're being admitted. We will start formally in 1 minute. Thank you very much. Good afternoon again, everyone. Welcome again to our Clinix webinars, the first one of the year. For those who've been joining us for the last 4 years, since we started Clinix continuing medical education webinars during COVID, I think they will know the drill. But because they are always new members of the audience, we are going to go a little bit slower today, so bear with us. These webinars are meant for development of people in the healthcare sector, healthcare professionals of all clinical disciplines. We also welcome managers in the health industry, both in public sector and in the private sector. We have a very interesting topic, very topical, if I may say, on NHI. And I think because of the topic itself, but also because of our presenter today, who will introduce very shortly, I think we've had a tremendous response with registration. Our system normally allows 1,000, up to 1,000 people registered. Our average attendance on a weekly basis is anything between 250 and 600. But this time we have over 5,000 people registered for this webinar, which is a record. And I think that's the reason why you see that we're starting a few minutes late, number one, but also because of it's admitting people slowly. People are still coming in as we speak. So the technical team is admitting them as we speak. But we will adjust to one of our basic house rules is that we will not allow questions during the presentation. So as the minister talks, we will allow the minister to do his presentation until the end. It'll take about 50 to 60 minutes, maybe. Minister will decide. And then we will then allow people to raise their electronic hands, and members of the audience can then ask questions or make comments. We will be able to attend to all of them, or as many as possible. We will also, the system also allows comments and questions to be typed in the chat box. So We will also attend to those at the end of the presentation during the Q&A session. So, but you can, in the meantime, put them in there. Minister will ignore them and just attend to his presentation. And we will attend to the chat box after the minister's presentation. I think just to, again, welcome the new ones, but also to say that we encourage anyone who would like to do a presentation on any clinical topic within the healthcare sector, clinical or management topic, to raise their hand. They can let us know that they would like to do a presentation, because we welcome new presentations. We've had presentations on many clinical disciplines, all the clinical disciplines, in fact. My name is Dr. Ernest Genoshi, and I'm here on behalf of Clinix Health Group, which has been sponsoring these webinars for the last 4 years. We thank the board of Clinix Health Group and the executive committee of Clinix Health Group for sponsoring these webinars, which we have been able to offer free of charge to all attendees. And I think we need to say that we hope that we will continue doing so. So for as long as people register, as long as you register for the webinars, we will be able to keep them going. The Clinix has registered with the HPCSA as well. We've got approval for HPCSA for them to accredit all our webinars. We've never had a problem with any of them for CPD points for attendees. If you are registered with the HPCSA, the professions that are registered with the HPCSA, and then South African Nursing Council also and Pharmacy Council also recognize our webinars. So all attendees, as long as you've registered on the form and you've put your HPCSA registration number, you will receive CPD points. They arrive in your mail about 3 to 4 weeks after the webinar. So it won't be immediate, 3 to 4 weeks, and you get an email from HPCSA themselves informing you of your webinar CPD points. The CPD points today, because of the nature of the topic, will be ethics CPD points, CEUs. We know that there are clinical ones and there are ethics ones, and many people have doing well with their with their clinical CEUs, but I think a lot of HPCSA registered professionals would have had HPCSA in the last 6 months that they are short on ethics points. So I think this is one case where you will be able to boost your ethics CPD points. I'm not alone today. I am joined by 2 co-presenters. I'm going to hand over to Dr. Victor Ramathisele to greet you and then hand over to the minister to do his presentation. Thank you. Over to you, Dr. Ramathisele.
Introduced, and I have the pleasure and the honor of introducing a gentleman who was born and raised in Pokwane in Haskukuni district in Limpopo, a very hardworking student and a political activist at heart. And he completed his medical studies at the then University of Natal in 1983. While being a very dedicated doctor, his well-known political activities include membership of several student, professional, and civic organizations, including his political home, the African National Congress, of which he has been a member of the National Executive Committee since 2007. Since 1994, he has served as an MEC, a member of Executive Council in several portfolios in Limpopo, before being appointed as the Minister of Health between the years 2009 and 2019. And after a 5-year stint as Minister of Home Affairs, he's back in the national portfolio of health. To take us through an update of the national health insurance, ladies and gentlemen, let me allocate and let me introduce to this webinar, Honorable Minister of Health, Dr. Pakishe Aaron Motsoaledi. Thank you.
Yeah, good evening, Minister. You can unmute yourself and you can start your presentation, please. Thank you.
Oh, yes. Yeah. Good evening, Dr. Kinosi. I'm sorry it was refusing to unmute. Sometimes these gadgets do like that. Can you hear me now? Hello? Dr. Ramatisela? Dr. Kinosi, am I audible?
Yes, Minister, you are audible.
Can I go on?
Yes, please.
Okay, thank you very much. Once more, I'm apologizing because I've logged in some 15 minutes ago, but when the moment comes, the gadget just let me down by refusing to unmute. Anyway, good evening, and I really need to thank you for responding in such large numbers. It shows the importance of this topic I'm going to deal with. I am not going to pretend that I'm dealing with a very easy topic. It's very difficult, and it's a much maligned topic because of different interests. People put it in whatever way they want. I am not trying to undermine you, but I want to argue that most of you, at least 80% of the things you might have heard about NHI are not necessarily true. I am saying so with conviction because I've addressed many, many groups of GPs, even during their collection of continuing medical education, CMD points, and I can tell you many of them, when they ask questions, you realize that they've got no idea. A large number of people get their information from the media, which, as you know, has got the tendency of distorting. And once something is distorted in the media, it never changes. The media works like the internet. Once they put something that is wrong there, to go and change it is a very difficult thing. And a number of people get their information there. So I've been addressing quite a number of people, political parties included, trade unions, churches, etc., etc. And I'm doing the same presentation. Some people attend all these sessions and come and complain that, no, I've heard about that before, and expect me to present something else. NHI is only one, and I know only one NHI. I can't present something else, and I can't say, because last week I presented this part, let me do progress now, because some people might be coming here for the first time. So if you have seen the presentation before, please bear with me. I am not presenting the nitty-gritties of national health insurance or universal health coverage. I'm presenting the overall strategy, the reasons behind it, what is happening globally, why we need to go that way. But I'm also going to spend some bit of time showing you how the present healthcare system look like. And you will make your own mind whether you think in solving South African problems, we need to continue the way in which you are doing. Lastly, there are people who believe that the only thing that we must fix is public health care, which they believe, some even go to an extent of saying it has collapsed, despite the fact that we all know that 86% of the population are still getting their health care there. So there are people who say, look, leave private health care, go to public health care and fix it. There is nothing to fix in private health care. I want to inform you that we don't agree with that view, totally don't agree. We are not the only ones who do not agree with that view. You might remember that we have put up a public market, health market inquiry headed by the former Chief Justice Ngobo, who have been with other health professionals, including a professor of medicine at Wits. They were given 6 months to look into the problem of private health care. They took 5 years because of the interest and the manner in which it was being challenged, and the fact that even people outside South Africa got interest and came in to present. And you know that there is a report about private health care, which shows that there are things that needs to be changed. So right from the beginning, anybody who believes all we need to change to have a good health care in South Africa is public health care will not be correct, and we will not agree with such a view. Now, let me start from really the beginning. I am assuming that even people who are not doctors join this. So when I go very, very low in presentation, don't think I'm undermining your standards. I just want everything to be understood. Kata, can you move the screen? I hope you are the one who's moving. Yes. Now, for you to understand the healthcare system, the World Health Organization has declared many years ago that any healthcare system in any part of the world consists of 6 building blocks. You may call them pillars. And as you know, when pillars of a building start shaking, or even if one of them collapse, that building is not going to be stable. So what can make a healthcare system unstable in any country? The first one is leadership and governance. You know that we are not only sharing this with health. In any institution where we are dealing with human beings, it might be health, it might be education, it might be a police force, an army, even a church, even an organization like the church. If the leadership and governance are not correct and appropriate, there are going to be problems. But in the healthcare system, you also need access to essential medicines and other commodities. Commodities like instruments to investigate, but even like infrastructure, buildings, etc., they are very important. Then the third one is the health workforce. And I want you to understand the health workforce goes beyond doctors and nurses. Many people think health workforce is only doctors and nurses. In a healthcare system, there are many other role players who are essential. For instance, you know that the ladies who are, it's mostly ladies, but I think there are guys there also. Forgive me for saying ladies only, who are there to sterilize instruments. If they go on strike, there's no way that the theaters will work, even if you have got all the surgeons there. Then you have got, so the health workforce goes beyond doctors and nurses. Then you have got health systems financing. I've put it in red because it's the subject of this whole, is the core and the subject of this whole debate on NHI and universal health coverage. That's why I put it in red, because I'm going to come back to it. Then there's health information systems, which I would like you to understand, because many of you are users of the system. Despite the development of technology, you'll be surprised to know that in many parts of the world, even in developing countries, they are still struggling to have an appropriate and a proper health information system. By health information system, we mean a system that will give you all the information you want, but more than anything else, that will trace a patient from one system to the other, meaning from public to private, from one doctor to the other, or from one healthcare worker to the other, not only doctors. That means everywhere where a patient attends for purposes of healthcare, this system must be able to trace them and give the appropriate information. You are aware that at the moment, we don't have such a system. And as such, there are many people who are treated by many doctors, given the same thing within a short period of time because they don't know. What I try to say, a patient can go to a hospital or a GP or a specialist today and get treated and choose to go to another one who won't know what has happened yesterday. They will still get treatment. That is still happening a lot in the public sector. People who are HIV positive do that a lot, hoping that one day, as they keep on visiting, one day they'll get a negative results and get relieved. So they keep on doing that. And you also saw that I'm sure many of you saw on TV after the bus accident in Zimbabwe late last year, where they saw medicines on the road that made the public go mad. The public was very, very angry, especially with the state, because they say we are playing with resources of the country. And they were asking me, the press asked me where the medicine was stolen. And I said it might not have been stolen at all. It might not have been. It might have been that people from Zimbabwe were moving from one healthcare facility to the other, collecting ARVs, as we know they are doing, and holding them together, and then try to make them cross the border. Because we don't have a health information system to tell them that no. But yesterday you collected these ARVs in such and such a clinic. So a health information system is important because it has been giving us tough time. In 2012 or 2010, I'm not sure of the actual year, all the 9 provincial departments of health has spent 4.5 billion rand by that time looking for health information system, acquiring them from providers, etc., etc. But none was serving this function I've mentioned. We even put a moratorium and say, please acquire no more health information systems. And we went to CSIR, Center for Scientific and Industrial Research, our own institution, and ask them if they can compile a health information system that will help us. It took them 8 years, they did so. We have even tried to pilot it in the Free State. Most hospitals in the Free State have connected to it. And we even tried it between public and private. A few GPs were connected to the system to see if it can work. We are not going to be rude and say the state has got a good health information system, leave the one in your practice. No. All we asked the CSIR was, can you give us a system that is interoperable, that can connect to all the systems that exist in our country so that healthcare professionals can just log into it without doing away with what they have. So we believe we have got such a system now, we are moving on it. Our biggest problem is connectivity. Then the last is health service delivery. What are the packages of healthcare that the citizens of the country receive, regardless of their status in the country? At the moment, you all know that only people with medical aid can tell you what's going to happen to them. They also, to some extent, for instance, if a woman is pregnant, what is the health service delivery package that the woman must expect to bring a normal child into this world? What must she expect? Most of the time, it will be women with medical aid who will know what is likely to happen. That they'll go and see a gynecologist, they'll be put under a scan. For delivery, they'll go to such and such a place. But they constitute only 14% of the population. What about the 86% of the women, of the population, who are depending on the public healthcare system? What is there for them? When you get TB or AIDS, what must happen to you? Very recently, you had problems about cancer. It is now our new pandemic, more than HIV. The issue of cancer, almost everybody now, just like 20 years ago when we could claim that everybody knows somebody who has got HIV/AIDS or who is HIV positive or who died of HIV. Today, we can also say almost everybody knows someone or has attended the funeral or has a relative or knows somebody, some neighbor, where somebody has died of cancer. Now, when individuals get that disease, what is the delivery packages that they don't have? And I'm repeating, only those who have got the medical aid to an extent know what to expect, but the rest of the population don't. Now, the problem with that, colleagues, is that healthcare is not about delivering one individual and giving them the best that the system can offer. It is about the whole population. That's why in United Nations, the Millennium Development Goals and now the Sustainable Development Goals of the world is about mortalities. Can you reduce maternal mortality? Can you increase life expectancy of a population? Can you reduce under 5 mortality, infant mortality? If you can't do that population-wide, you will never be able to reach those goals. But the goal of treating one individual, one after the other, does not help us reach the goals, whereby we'll be very happy that we are heading somewhere. But in order to reach these goals, you have to make sure that these 6 building blocks are balanced. Next. Now, I want to divert a bit and take you back to 1978. That's exactly 48 years ago this year. In September 1948, the World Health Organization, the UNICEF, United Nations Children's Fund, co-hosted a meeting at a small town called Alma-Ata in the former Soviet Union, which is now in a state called Kazakhstan. That conference was convened because the World Health Organization was worried about the overall direction of healthcare in the world. What was worrying them is that in the constitution of the World Health Organization, when it was formed in 1948, the conference described health as not merely the absence of disease or infirmity, but as a state of good physical, mental, and social well-being, and went on to say it's a fundamental human right, which means every person who's described as human has got a right to health care. They were worried that that has been described in 1948, but yet it was not happening in that way. And that conference emphasized it. That's why you see on the screen there, declaration number 1, where they are declaring again that health is a human right. But you know very well that in the South Africa of today, good quality health care is only for the highest bidder. It's provided for those who have got the means. Ordinary people may get health care, but not good quality health care. So Alma-Ata emphasized that once more we want to emphasize that health is a human right. But number 2, on declaration number 2 there is even more serious. It says the existing gross inequality in the status of people, particularly between developed and developing countries, as well as within countries, is politically, socially, and economically unacceptable. It is therefore of common concern to all countries. I want to emphasize these words, colleagues, because some people believe, oh, this NHI is just a political ploy. Oh, this NHI is going to collapse the economy. Now, colleagues, health and economic development are inextricably bound. I want you to know that. Without a proper healthcare system that can reach anybody, no country can build a viable economy. And I want to challenge you today to go back to 2010 or before 2010, maybe 2009, before we launched the world's biggest HIV counseling and testing campaign. If we did not do so at that time, many companies in South Africa will have collapsed. Many institutions will have collapsed. Even the institutions you are running, because of poor health care, of people who are contracting TB, HIV, AIDS, and people who had TB and HIV, AIDS were related to those who were getting diabetes without being treated, and cervical cancer and all that. So it was a big mess. If we did not launch that campaign, we were going to be in trouble. And yet, when we launched it, people were asking us questions. Where are you going to get the money from? Can you afford it? Can you take care of so many people? This is a dream. This is going to be very expensive. This will collapse the economy. And my answer was one. Can we afford not to? Can you afford not to make people healthy? Because if you don't do so, your social life, economic life, even political life will be in trouble. So that's what Alma Ata said. Now, you know, if you are a South African, that we have got gross inequalities in the health status of people or in the provision of health. Alma Ata ended with a slogan, health for all by the year 2000. There was a dream at that time, and the dream was not by the World Health Organization and UNICEF only. 164 countries around the world attended this conference in Alma Ata, and all 164 countries agreed on the concept of health for all. And all means exactly that. It means no one ought to be left behind. But that never happened. That dream of health for all never happened. In fact, it's getting worse in many parts of the world, including our own country. And why? Katla, can you go back to the slide before? Yes. The World Health Organization came to believe why such noble ideas as health for all, or as health being a human right, why they are not being achieved. And they came upon a conclusion that of the 6 building blocks of a healthcare system, the health system financing around many parts of the world has gone wrong. The manner in which we finance health. And financing health is not about the budget, no. It's about the method in which a country finances each health, whether you are going public, whether you are going private, whether you are going to a pharmacy, anything that you purchase or you get or you acquire to make you healthy, if it's computed together, it gives you how the health system in that particular country is financed. And the World Health Organization argued that it has gone wrong in many parts of the world. Next. Now, next again. Now, the World Health Organization also concluded that in order to finance health, 3 methods are known globally. We don't know any 4th method of financing health. We only know 3. Those maybe who are more advanced and know other methods can say so during the question time or the debate. But at the moment, we know only 3 methods. Next. Yeah. Now, before we go to the 3 methods, a professor of health, health economics at London School of Economics, Professor Robert Hayes, wrote this article which appeared in Daily Maverick on the 22nd of May 2025. The article says South Africa should ditch its American healthcare system. What does that mean? What is an American healthcare system? Why should it be ditched? Why is South Africa running an American healthcare system? What is wrong with the American healthcare system? For me, it was not the first time that I heard that. In 2013, Dr. Margaret Chan, who was then the Director General of the World Health Organization, before that, she was the Director General of Health in Hong Kong. Then she won a position as the Director General of the World Health Organization. She asked me a question when we were in Geneva for the World Health Assembly. She said, Dr. Motsoaledi, South Africa is running a British healthcare system. Everything that you are doing in healthcare is British. Your curriculum is British. The titles of your doctors or nurses of all health professionals are British titles. And she was right, because when I was still a medical student, in the early days of my life as a medical student, I know that in South Africa to be regarded as a specialist, you can start in any university, you must go and write your exam either in Glasgow or in Edinburgh or in Dublin, etc., etc. But now we do have a College of Medicine here, which is also built along the British lines. We just took the title of the Fellowship of the Royal College. We removed the word royal because we're not royalty really. But so Dr. Chan was saying, everything you are doing is British. But when it comes to financing, you become American. And she said, when you were on this British highway of healthcare, when did you off-ramp to the American health financing system? And she said, don't you know that the health financing system the Americans are using is the worst that America has ever bequeathed to the world? What was she talking about? I'm going to try and answer both Professor Hayes and Dr. Margaret Chan on this issue. Next. Now I'm going back to the health financing. On the screen there, the graphs you see were developed by the World Health Organization in 2009. There is called National Health Accounts Dataset. In other words, go country by country, find all the three methods of financing healthcare, find how they are. Now, the first method of financing healthcare, as you can see there, is called mandatory prepayment of health. Khata, if you are able to, you can also use the arrow to help me point. You can point to the mandatory prepayment of health there, which, as you can see, is blue on the graphs there. And in South Africa, mandatory prepayment of health does not exist. Only the budget, because budget is part, it's not mandatory, but it's part of mandatory prepayment of health. It's not the system itself, it's part of it. So the mandatory prepayment of health exists in all those countries that I've put there. In South Africa, the only part that we call mandatory prepayment is a budget. It's a budget. Now, the second method is voluntary prepayment. As you can see, it is red there, red or brown, voluntary, on those graphs there. And it has got a name in South Africa. It's called a medical aid, because you are paying for health before the person is sick, but it's voluntary. Whereas mandatory means if you introduce it in your country, nobody can opt out of it. That's why I'm saying a budget is mandatory prepayment of health, because once a budget is read, no South African can say, no, I'm not part of that budget. It's not possible to say so. So it's a mandatory thing passed by Parliament. Then the last is out of pocket, which is green there. As you can see, a number of countries are doing away with voluntary prepayment and out of pocket and moving to mandatory prepayment. Out of pocket also has got the name in South Africa. It's called cash. Whether you are paying cash to a doctor or whether you are doing the other payments that are wanted, because sometimes you are on a medical aid, it pays this part, you pay that part, the issues of co-payments. Now, on the extreme right of the screen there, you are seeing two countries. That is South Africa and USA. You are aware that they've been put away from others. That is what Professor Robert Yates was talking about. That is what Dr. Margaret Chan was talking about. The two countries have been declared outliers by the World Organization. Why is USA and South Africa called outliers? They are supposed to be twins, and it's ironic because now we are fighting ferociously. We and the Americans are fighting ferociously, but we've been declared outliers. Why are we declared outliers? It's because we are doing the same thing. Our predominant method of financing health is cash and medical aid, whereas the other countries are not doing that, as you can see, starting from Australia there, Austria, Belgium, etc., etc. And you can see that countries like the UK, which have got NHS, which is being maligned, the UK there is the last on the first set of graphs. Yes, it has got a very high mandatory healthcare finance system. Can you move on? Now, this is Africa. The World Organization is a disaster in the making. Those who are observable can observe very easily. Those who are observant, I mean to say, can clearly see why. The predominant method of paying for health in Africa is green, meaning out of pocket, meaning cash. You know? Now, why is it a disaster in the making? Because when you move to Europe, the ordinary person you'll meet on the street is likely to be having spare cash in their pockets. They are well-to-do. In Africa, an average person is poor. But when they are sick, we expect them to pay. That's what we call out of pocket. The mandatory prepayment in Africa is mostly the budgets that are read in various parliaments. But you also notice something. Khatla, can you go to South Africa to that voluntary prepayment graph, which is very high? Yes. You see South Africa there, it has got the highest voluntary prepayment, which you call medical aid. And on the extreme left is Namibia, because Namibians are using South Africans' medical aids. The other countries are not doing that. But I want you to also notice something. The last two countries on the extreme right, Guinea and Sierra Leone, you know how they were ravaged by Ebola. And the World Organization was attacked. Why they couldn't pick up this Ebola earlier? They couldn't, colleagues, they couldn't. Because before you pick up a disease, it is doctors in the field who tell us. For instance, when we caught listeriosis that time when it occurred, we were tipped by doctors. They started raising an alarm that in our practices or in hospital, we are seeing more and more people who have got listeria, and we never saw so many people before. And the National Institute of Communicable Disease investigate and found that indeed there's an outbreak of listeriosis. But now in Sierra Leone and Guinea, why was it not picked up? Because every individual there, for them to go and see a doctor, they need cash, but they are very poor, very poor. So they let the disease spread in the far rural areas where people were just sick but not going to see any doctor. By the time the World Health Organization picked it up, it has spread all over the region. And it's because of what you see on that graph, what you see there. I mean, where out of pocket payment is more than 95% of the total financing of health. I mean, it's in Sierra Leone, and more than about 97%, as you can see, in Guinea there. It is terrible, and that's why they call it disaster in the making. Next. Yeah, now, the World Organization said, if we are to solve this conundrum of healthcare financing, where some are paying cash, others have got medical aid, others have got mandatory system, the World Organization believes the world must have universal health coverage. Universal, meaning we are covering everybody. Now, we call that universal health coverage NHI. Countries call it differently, but the generic term is universal health coverage. Next. Yeah. Now, there is an argument in South Africa that we are not ready for any for national health insurance because we are very poor because our healthcare system is dilapidated, because there are many people who are unemployed, because the tax-paying population is very small. We need to fix those things before. I'm here this evening, colleagues, to tell you that that is not true. For the simple reason that all the countries in the world that came up with a system of universal health coverage and call it in different names, many of them were responding to a crisis. It's not because they were ready or they were rich. No, definitely, there's not a single country that can be described in those terms. The fact that you hear it all over, even by analysts, even by the press, does not make it true. The first one I want to start with there is the UK, the National Health Service, which many of you would like to call has collapsed. That was in 1948. UK was responding to the Second World War crisis. The Second World War that ended in 1945. If you remember, if you know history, after the Second World War ended in Europe, there was a Marshall Plan, a plan called a Marshall Plan to rebuild Europe after the crisis caused by the Second World War. And as you know, the British were the ones that were attacked heavily by Hitler. And when they also wanted the Marshall Plan, they were asked a question: how do you rebuild your economy when your people are sick, they are poor, and they are unemployed? High unemployment rate, high rate of poverty, high rate of illness. And you can't treat them because there's no money, because you needed cash. That's why Britain came with the National Health Service, or NHS. I know many people in South Africa do not like NHS, and they claim that the British are rushing here to South Africa to collect treatment. Their owners love it. The British love National Health Service. The few who are complaining, who are not getting their way, are exactly like that, a few. Most of the people love it. That's why one government after the other went on with the National Health Service. In June this year, we visited the UK. And when we arrived there that week, the UK has just pumped in 29 billion British pounds. That will be about 660 billion South African rands. They pumped it into NHS. Are you saying they are so stupid that they pumped that amount of money in the collapsing system? In the same week we were there, they launched a 10-year program to turn the NHS around, not to leave it to turn it around, because they knew where they committed the mistake, which is what? Which is to finance a curative healthcare system and leave prevention or primary health care by the wayside, which is also the mistake we are doing now in South Africa. Canada, same thing. They were responding to the Second World War. Thailand, which put up theirs in 2002, was because of the Asian financial crisis of 1997. Many of you might forget there was a financial crisis in Asia in 1997. Ministers of health, ministers of finance, finance ministers, treasury ministers were asked to sit together to see how they avert this crisis in Asia so that it doesn't spread all over the world. After their initial meeting, they realized the problem is bigger than them. They called heads of states, and heads of states came together, and guess what? G20 was born. The G20, which was here in South Africa in November, was actually born because of the financial Asian crisis of 1997. And Thailand did not just fold their arms. They changed their healthcare system to what is called UHS, or Universal Coverage Scheme, or 30-baht scheme. Next. Same as Indonesia, they were responding to the Asian crisis because Indonesia is also in Asia. Then Brazil has got a system called SUS, or Sistema Única de Saúde, which they introduced in 1990. Those, again, who care about history and economics will know that Brazil and South Africa were regarded as the most unequal countries in the whole world. The Gini coefficient being a measurement between the rich, the gap between the rich and the poor. The Gini coefficient was the highest in Brazil and South Africa. But in 1988, Brazil declared healthcare as a right. And they argued that if healthcare is a right, why should we not? I mean, why should it be offered only to the highest bidder? And they changed their system. They launched the SUS, or Sistema Única de Saúde, which is their form of universal health coverage. At that level, poverty levels in Brazil were 25%. Now, it is 3.3%. And if you ask the Brazilian government, they tell you it's because of the changes we made in healthcare, where we made health universally available to everybody. China does not have a universal health coverage, but they went to re-socialize their healthcare after SARS, the severe acute respiratory syndrome of 2002. Next. Khatla, can you move the slides? Yes. There's Mexico. Professor Julio Frank, who was the professor and head of public health at Harvard University, who came in from Mexico. After leaving Harvard, he went to Mexico and he introduced what is called Seguro Popular, or popular insurance for everybody, in 2001. And I asked him personally, because we used to go for lectures at Harvard. He said they did it to reduce health disparities. Then come America, the richest country in the world. Obama came with what is called Obamacare. It was not called Obamacare officially. They were doing it to try and ridicule him. It was called affordable health care, because healthcare in America was becoming unaffordable because of the system they are using. And he tried affordable health care, but it failed because there was political opposition and huge interest groups, just like we have in South Africa today. Can we go on? Yes. Now, let's come to healthcare financing. How do we finance healthcare in South Africa? The World Health Organization has declared that healthcare financing must not be done per budget, but per GDP. It must not depend on the budget of a country. We must look at the GDP. That means the mandatory prepayment of health, the voluntary prepayment, the out-of-pocket must all be put together and checked. How do they compare with the GDP of a particular country? Meaning that countries are going to spend not equal amounts, it's not possible, but the amounts which are comparable to 5% of their GDP. Now, in South Africa, we have lost long past that 5%. We have long past that 5%. Where are we? We are at 8.5% of the GDP, which amounts to 570 billion South African rands. I am here to inform you that's a lot of money. 570 billion South African rand is not the budget of health in South Africa. It's not. It is the total health spent in South Africa. Now, if you are already spending 8.5%, which is not different from many countries in Europe. Europe is generally between 9.5 and 10.5%. So we are in the same bracket as Europe. Then people will ask exactly what's wrong. Of course, depending who you are, some people will say, no, it's caused by corruption, it's caused by mismanagement, it's caused by incompetence. I'm not going to challenge all those things. I'm not going to challenge all those things. And I can see There are people who are busy on the screen trying to distract me and attack and all that. But I'll keep on presenting. And somebody says everybody in Europe pays tax. Everybody in South Africa pays tax also. I'm going to challenge you at the end of this meeting to show me one individual in South Africa who does not pay tax. Because as far as I'm concerned, the tax that the state spends on various services comes from three sources. It comes from personal tax, which is number one. It also comes from corporate tax, and it also comes from VAT. And VAT is number two. It's paid by everybody, even the poor, even the poorest of the poor, because anybody who has got into a shop has paid VAT. That is why when the minister wanted to increase VAT, there was a big uproar. So if VAT is insignificant, why was there an uproar? Why didn't people say no, because personal tax is being paid, there's no problem? They didn't say so. So it is not true that there are many South Africans who don't pay tax. They pay VAT. It's a very important tax. If you stop it, South Africa will collapse. That I'm dead sure about. Now, the problem in South Africa, which many people, not many of you, are trying extremely hard to try and deny, but it's a fact, is that 51% of this 570 billion, or 8.5% of the GDP, is spent only on 18% of the population. And the remaining 49% goes to 86% of the population. That is a fact, and it is happening. Next. Who are these 14% of the population? It is the cream, a la cream of South African society. Teachers, doctors, nurses, managers, including CEOs of companies and entities, the police, the army, the judiciary, the president, members of parliament. They are all part of the 14% of the population. In other words, people who are on medical schemes. But now, I've been told many times that the money in medical scheme is private money, and we must stop complaining about it or even referring to it because it's money for private individuals. I've even been told by people that they are paying tax and I must leave them alone. I must take their tax and go to treat the poor and leave them to enjoy their money. Now, I will have done so and I will shut up if it was true. But I mean, government, I know. The state subsidizes people who are on medical aid, and the subsidy is 70 billion. That comes from Treasury every year. The second amount is tax credit, tax rebates of 33 billion rand, where everybody who is on a medical aid, regardless of who their employer is, the state through SARS give them tax credits worth 33 billion. These figures are last year's figures. After the salary negotiations, these figures will have changed. I've got to believe that the subsidy must be 75 billion and the tax rebates must go to about 35 billion. So it's a lot of money that is subsidizing those of us who are well-to-do. I'm saying we're well-to-do because before you are on a medical aid, you need to pay. That's why we've got cartoons like this, when equality is just a sound bite, where you have got very poor people in a public hospital this way and very rich people who are on private health care. That includes all of us on medical aid. That includes me too, because I am on a medical aid. Next. Yeah. I want to show you again that spending a big portion of your GDP on health does not guarantee good outcomes. I am using the BRICS countries to compare that. As you can see, number one, on total expenditure on health as a percentage of GDP, number one is Brazil there at 9.89. Can you point to Brazil? 9.89. No, yeah. Can you go down? Yes. There is Brazil, 9.8 now. Number two is on the extreme right, is South Africa, on 8.5, which I've told you. We are spending as a percentage of GDP on health more than Russia, even more than China, which is still at 6.8%. I'm quoting Russia and China because they are bigger economies than us. China is still at 6.8%. It is the second biggest economy in the world. India is put in red because they've not even reached the 5% recommendation of the World Organization. But let's go to health outcomes. What are the health outcomes? Starting at the bottom there with life expectancy. You see in South Africa is red. It's the lowest life expectancy, despite the fact that in expenditure we are overall number 2. And that life expectancy of 61, 67, 64 came only after we launched the world's biggest antiretroviral treatment in the world. Can we move over to yeah? And as you can see, most of the rates are on South Africa and some on India, because India is spending very less. But you also see in the middle there, where every country is red. Can you just move, yeah, around that? Yeah, where all the countries are red. That's non-communicable diseases, because there's no country in the world that can escape non-communicable diseases. So their expenditure, regardless of the expenditure, it is red, which means all of us are not making it when it comes to non-communicable disease, which is a problem. But for South Africa, the rate is on quite a large number of things. Next. Next, yeah. Now I want to show you the play here with medical aid schemes and some of the things that we want to change. In 2010, medical schemes raised 84.7 billion rand. Khada, you can keep on pointing. Yes, 84.7 billion. And the money is distributed like that. What is my gripe? Our gripe is down there at the bottom with GPs. GPs got only 6.2 billion of 84.7. What is my gripe? GPs are doing primary health care, and they are providing health care at very reasonable cost, but they are getting very little. At the bottom there, you see written rate non-health care costs. Non-health care costs, which is more or less double what the GPs are getting at 11.6 billion. What is non-health care? It's people who don't touch a patient at all, who just put paper and pen and paper and all that, but they earn more than GPs. That's my gripe. Because under NHI, we said our port of call is going to be GPs. And it was like that when I was a medical student, by the way. It was like that. Nobody went to a specialist or a tertiary hospital without going through GPs. In the legal system, it's still like that. Nobody goes to see a senior counsel who is so expensive without being referred to by lawyers. You know, I did not talk much about dentists. I see somebody's complaining about dentists there because of their numbers. I'm talking about GPs who are found everywhere. Not that I'm undermining dentists, because I don't have time for all the things. I'm just giving you a few examples. Fast forward 2022, the money moved from 84 billion to 218 billion. And guess what? Guess what? The biggest amount of money goes to private hospitals at 77 billion, then to specialists who moved from 19 billion in 2010 to a whooping 59 billion within that short space of time, making them get 27% of the slice. The GPs moved from 6 billion to 11 billion. But at the time they were getting 6 billion, it was 7% of the total healthcare cost. Now it's down to 5%, meaning what? We're moving away and away from primary healthcare, more and more to a curative healthcare system, which is very expensive. That's basically what we are doing. And that's why we call it the American system. The total non-healthcare cost moved from 11 billion to 18 billion, which is still very high as far as I'm concerned. And that is the American healthcare system, because in America, most of the money in healthcare doesn't go to patients. It goes to people who are running the system. Next. Now, the racial divide of healthcare in South Africa. Despite our democracy since 1994, If you look at the slide there on the screen, in 1960, when you go to a private sector, you find mostly white people represented by a black bar there, and the black people who are blue, very small. If you go to the public sector in 1960, it's the other way around. The graph turns the other way, where black people are in the absolute majority in the public sector, and the white people are few. You fast forward 2015, the graphs are still the same. There's still a racial divide between black and white. So we're still running a racialized healthcare system despite our democracy. Now, there are arguments, even for those who have taken us to court, that in the medical aid, the 9 million people who are on medical aid, the majority of them are black, simply because of population numbers. Blacks are 80% of South Africa's population. That is that. But what is the real story here? The real story here is that, can you move on? The real story, can you move on, Khatla? The real story is that as we are sitting here, medical aid, since their inception in 1967, covers only 10% of the black population. In the white population, they cover 72%, meaning what? 90% of blacks are not covered through any type of health insurance, and 28% of whites are not covered. All of them are looking at the state for help. And that's the situation in which we are. And we need to respond to that situation. This is a fact. Next. Next. Now, this graph is from the World Bank. It's not even from the World Health Organization. It's the World Bank. They are comparing 64 countries and see what percentage of GDP are they spending on health. As you can see there at the bottom red breaking line is the average for Europe. South Africa is the vertical red line there. That's our 8.5%. But at the top of the pyramid, at the top there is the US, 22%. You can see the gap between the US and Europe, or any other country for that matter. It's a huge gap, such that 43% of the total healthcare expenditure on this planet is in one country, that is the US. And we are moving in the footsteps of that US. Can we move on? Can you move on? Yeah. Now, there are people who believe we don't care about healthcare facilities. We just want to implement NHI. This is because it's the narrative that is there. I want to show you this about Lusukisiki in the Eastern Cape, where they never had a clinic. They've hired a building from Metropolitan Life, and after clashing about payments, the then MEC told Metropolitan Life to go to hell. They went to hell, but they took along their building, and there was no clinic. Next. And this, next.
I'm trying to move over to the infrastructure minister. Is it
Can
not
you
where we
move?
should-
No, don't move to the next
okay.
slide, please.
Okay.
I'll tell you when to move to it. Yes, please. Yes. This is what was put as a clinic in Lusukisiki, which is very bad. This is very bad and highly embarrassing. And I'm the one who was attacked from this. And one of the weekly newspapers went to Lusukisiki. They took pictures of this and named them NHI. They said this is NHI. When your minister talks of NHI, this is what he's talking about. Next. We went to Lusukisiki. Next. And this is what how patients were being treated. Next. We moved in and responded and built up a community health center in Lusukisiki. This is what it looked like. It was never reported anywhere in the press, not on TV, not in the papers. Even the original newspaper that put 10 there and says an NHI clinic They never went back to say, oh, the situation has changed. They never did that. Next. Yeah, this is exactly what it looks like. The center sees 500 patients, and there are many more that were put up. Kata was trying to put them, but I'm trying to save time. There are many more infrastructure that were putting up in preparation for NHI. Next. Yeah. Now, I want to ask colleagues here, do we have an example of what an NHI-like structure can achieve? Meaning what? If you treat people equally, regardless of their socioeconomic status. This is shown by the manner in which we dealt with HIV and AIDS. Next. Yeah, this is the graph of maternal mortality from 2005 until 2022. By 2010, our maternal mortality was at the top of the mountain. It was very high. And when we launched the world's biggest HIV counseling and testing, in the Department of Health, they argued that people who are on medical aid must be made to pay. I refused. When you are fighting a disease, you don't do that. You can imagine with COVID, if we say only people with money must be treated for COVID, you can imagine what will have happened to the whole population. We said anybody, whether you are a billionaire, whether you are a gardener, whether you are a security person and all that, you come to test, you don't pay anything, and if you are positive, we give you ARVs, which is what we did. One of the effects was to drop maternal mortality from that top of the mountain in 2010 to just below 100 in 2019. But it shot up again because of COVID. As you can see, that peak there, that happened between 2019 and 2022 is COVID. But when COVID, when COVID went away, maternal mortality started coming down again. Next. Next. Now, this is the NHI type of practice that we want. Why can't we do that for other diseases? Next. Yeah. Can the healthcare system survive the present health financing system? While subsidizing people to be on private healthcare happens every year, unimpeded, but the budget of health is subjected to severe austerity. As you can see there, the budget of health, it shows the budget of health, that red graph, which in 2020 was at the peak. Why? Because all government departments, money was chopped off from all government budgets to go to the Department of Health to fight COVID-19. I was in Home Affairs. I lost 500 million, half a billion, to be taken to the Department of Health. But after COVID was down, the budget keeps coming down, down, down. But the population is growing, and that's why we need to change. Next. Yeah. Now, there's the argument about the cost of NHI, where some people say it is 1.3 trillion, which is not true at all, because I know that figure of 1.3 trillion was arrived at by assuming that everybody will go to a private hospital, never to a public hospital. Many people don't necessarily want to go to private hospital. They just want to go to a hospital where they'll get good care if the resources are spread evenly in the healthcare system. So to assume that under NHI, we're saying everybody will go to a private hospital and the cost is 1.3 trillion. It's a deliberate distortion, which was done by Momentum Live. I asked for a meeting with them to ask them why they do that. They said they were doing scenario planning and the media picked up that and said it's the cost of NHI. Next. Next, yeah. The issue of corruption, there are many people, and I've just seen one now on the screen, arguing that corruption is the one that will make NHI not happen. If you read the NHI Act, you will realize what steps we've taken, but also the issue of Tembisa cannot represent what must happen to human beings in the whole country. And the issue of Tembisa, where some scoundrels went there to fetch money and buy Lamborghinis and all that, cannot be the reason we must use that people must suffer great inequalities in healthcare because there's corruption. We must fight it. That's why we took a decision with SIU, and we are going to carry it up, that at least 90% of that money which was taken from Tembisa Hospital must be recovered. There's no question about it. We are going to do so. The few Lamborghinis there that were recovered, that's not the end, it's the tip of the iceberg. Some of the people who did so are already bringing back the money. I'm sure you are aware of some workers at the hospital who said they can't sleep because they know we are coming after them, who brought back, a very junior official brought back 13 million. I have worked for more than 42 years of my life. I don't even have 42 million 13 million in my bank account. But that individual brought back 18 million. We're going to follow this money. We have got their pensions. We know they've got houses. I can tell you, wait and see. But we also know that in the medical scheme, they are talking about leakages and inefficiency of 28 billion. That's not a good reason to say no. That system must be done away with altogether. And NHI is going to be a Section 3A public entity. It's not going to be the Department of Health that is running this. It's a 3A public entity. You will ask me that all the public entities have collapsed. I was working in Home Affairs. We had the government printing works where all your security documents, including your passport, your ID, birth certificate, are being printed. The government printing works, when I arrived in Home Affairs in 2019, was making a profit of R500 million. And it was disturbed by COVID because there was no work being done, and it is moving on again. And it's a 3A public entity. So it's not a law that the 3A public entity cannot work. Now, terms and proposals that are being budgeted around, there are people who say we must do a risk equalization fund, but only for people who have got medical aids. My question is, what about the rest of the population? There are people who are calling for low cost benefit options or LCBOs, which are very problematic for me. Very, very problematic because patients don't choose the disease that they must suffer from. Next. Yeah. Colleagues, let me stop there and answer your questions, some of which I've seen they were already being put on the screen, but not as questions, but as a battle against what I'm saying. But in a democracy, you do accept such things and you know they will happen. But I'm ready to take your questions. Thank you very much. Dr. Kinosi, I moved over your 60 minutes by 5 minutes. Please forgive me for that. Thank you.
Very much, Honorable Minister of Health, Dr. Aaron Motsoaledi. Yes, we do understand that you'd have overstepped a little bit on the minutes, but given the seriousness and the importance of the discussions and the topic and the matter at hand, I think that is quite understandable. We really thank you for the preparation you have put into this presentation, the details, and your attempt to answer a lot of the questions long before they were asked. I think you've covered quite a lot of the questions that a lot of people would have asked, or a lot of attendees would have asked already. But without much ado, let's go into the questions that we have and put them through to yourselves. And then later I will give the opportunity to Dr. Kinoshi to go through some of the questions that were received online. Can we go through to online question?
We have
to you.
Okay.
Thank you very much, Dr. Ramatisela, and thank you very much, Minister, for a very inspiring presentation. We've grouped some of the questions because some of them are similar, and maybe we'll start with this one. It has been asked by several people, which says exactly how, when will NHI be implemented? I think meaning where are we and when is it going to be implemented? That's the first question. And I think some of them say it is overdue. I'm just paraphrasing what they said, Minister. And I will go to the next one after Minister has responded to that one. Dr. Ramathisela?
Do you think we'll finish if we go question,
Over to you,
answer,
Minister.
question, answer? Hello? Yeah, I propose that it will be very difficult. We'll stay here for the whole night. Well, if people prefer it that way, I won't get tired because that's my job. I was just trying to raise an issue here that if you question, answer, it may take longer. Shouldn't we take maybe 5 sets of questions? I'm just proposing. But if people prefer question, answer, I'm ready for that, definitely.
Thank you, Minister. Thank you, Minister. I think what we will do, we'll take a group of questions as you have suggested, and within that, I would also want you to address maybe the implementation in general, because what has been said on various occasions is that NHI was always going to be implemented in phases. In fact, at some point, phase 1 was going to be between 2023 and 2026, phase 2 from 2026 to 2028. And the first phase will talk about establishment of the NHI fund and its governance structure as a transfer of the management of central hospitals to the National Department of Health, and so on and so forth. It will be important for the Minister just to give us a sense maybe of the phases again, and maybe to tell us exactly how far we've gone in implementing some of the programs within those phases, and if there have been delays or some have been fast-tracked, what progress we are making in that regard. I think that's going to be quite important. But what I will do, I will hand over again to Dr. Kinoshi, for Dr. Kinoshi to take a group of questions, and then you can take all of that into one response, and then we can see how it goes. Thank you.
Thank you very much, Dr. Ramathisela. One other question, I think this must be from a GEMS, member of GEMS Medical Aid Scheme, Minister. I think it's Pagamisi Lembe. He says, what about us who are using GEMS? Must we cancel our membership during NHI? Minister, I think that can be addressed. There's also a question from there's a question about tax. There are quite a number of questions actually with a similar tone. Are we going to be is our tax going to be increased, and to what extent will everyone be required to pay towards NHI? That's another question. So it's all about funding, where I think some of it we've covered, Minister, but there's a question that you want to know whether people will be taxed. Will they be paying more than what they are paying in the form of tax or not? And there is David McCabe says NHI funds will need to be ring-fenced so that they're not used for other for roadworks, for other ends, but just only for health. So ring-fencing of the NHI fund the resources. There is a question from Maleho Mudisapudi. Maleho Mudisapudi says, tell us about, Minister, please tell us about the certificate of need. So there has been issues around certificate of need that Minister may touch on. Maybe let me take the last one for now. This is probably from a GP. Probably it's Dr. Pindilem Nomakwe. I hope they don't mind mentioning who is asking what. But he says, Minister, are you aware of the OHSE inspection tools imposed on GP practices, which will need to close, and this will lead to closure of most GP practices? ahead of NHI. So I think there's probably some misunderstanding there that needs to be clarified. People are afraid that they will be inspected for their practices to be certified for accreditation with the NHI fund. So they're asking about the tools and so that are used by OHSC, that they may lead to closure of GPs. Maybe let me stop there for now. Dr. Ramatison.
Over to you, Minister. I think the questions are loud and clear.
I want to answer a question which I saw on the screen, which Dr. Kinusi did not read. They are saying which model of universal health coverage is South Africa using. I explained universal health coverage as defined by the World Health Organization. It has got two parts to its definition. It simply says everyone. By everyone, we mean every human being on this planet. Everyone is entitled to good quality healthcare system. That one, nobody's challenging. It will be a shameful day if anybody challenges that. Everyone is entitled or has got a right to access to good quality healthcare system. That's the first part of the definition. The second part, which is what is causing war, or which is what the world is fighting about, it says, and if you access such a healthcare system, you must not be subjected to financial hardships. That is the war that is the one that has caused war, because you know money is the root cause of all evil. You must not be subjected to financial hardships. Why is the World Health Organization doing that? Because there are people around the world who are counted, not in millions, but in billions, where the family was not classified as poor under the poverty data line of the United Nations. You know, United Nations have got figures from country to country. How do you say this particular family is poor? And what is the poverty data line in that particular country? Now, around the world, there are a lot of people who were not classified as poor, but somebody got sick. The woman, the family get breast cancer. The child comes with leukemia. The husband has got a brain tumor and all that. Many families go and lavish into deep poverty because of ill health. Should we encourage a world like that? Should we live in a world like that? So for the countries to get out of that, they put either NHS, NHI, SUS in Brazil, etc. No one country can be identical to the other. But our NHI is based on the British model, but it's not going to be identical. It can't be. Countries are not the same. It's based on the British model because our healthcare system is already British. You know that very well. And that's why we visit a lot of NHS to go and see what they are doing, etc. I just thought I need to settle that. Now, when is NHI going to start? Let me tell you, NHI is never going to be an event. It's going to be a process, which I want to believe has already started. If I have time to show you some of the plans we have got about infrastructure, about committees, etc. So it's something that is a lifelong implementation. Many people believe we'll put a date and say tomorrow is NHI, on this day it ends. The UK has been having it for 77 years, NHS, 77 years, but they are still implementing even now. They are still changing things. I've told you they've just injected 29 billion British pounds in June. They've just thrown a new 10-year model, which they are going to do, which are going to improve. So NHI is not something that we can point out and say it has started now. It's a process, but let me simplify it a little bit better. On our side, we believe once the NHI fund is established, the first port of call is at the beginning of life. Pregnant women. There are 1.2 million pregnant women in South Africa every year. Out of the 1.2 million, 140,000 are on a medical aid, either of theirs or their husbands or what, as dependents. They are on a medical aid. The whole 1,060,000 are using the public sector, with all the shortages that are there, as you know them, because 80% of specialists are in the private sector. That's a fact about South Africa. So when we start, we are going to say every pregnant woman, regardless of their socio-economic status, must be entitled to a particular package. And what will package look like? How many times must this woman go to see a GP with the NHI fund pay? How many times? 2. How many times must this woman go to see a specialist, a gynecologist in other words? 3. How many times must the woman be put under a scan, and for what reason, to check the pregnancy? Not what we are doing today, where every visit we put a scan and we tell women the sex of the child. That has got no medical benefits. You all know that. It just excites people, but it doesn't benefit healthcare. So we are going to put such a package and then say at the time of delivery, what is there for this woman? Because those who have got medical aids have got good delivery systems. Then after delivery, the baby. What is the package of this baby? Until even when they go to school. Now you are aware, the Department of Basic Education has just decided on studying very early in life by making sure that we've got a grade R, that 5-year-olds must start going to school and start being developed. Minister Kwahube has mentioned it on Monday, that if we are to improve the education system, we must start very early. At the moment, not every child is going there. During the course of our piloting of NHI, which people believe has failed, we have gone through more than 3,500 kids to check their eyesight, their hearing, and their oral hygiene, their speech. Believe you me, it was scaring. I couldn't believe. I've been a doctor for many years. I never believed there are so many kids who cannot hear. But they are at school every day. And the state is paying money for them to be at school, but they are gaining nothing. There are kids who cannot see very well. And there is an eminent ophthalmologist who once asked me that I'm seeing children of the rich coming for me to test their eyes before they go to school. What about children of the poor? Why can't we have a system where everybody is put on a correct sitting so that we give them the same start in life? So when we say we'll have started NHI, is that it's going to be a process over many, many years. And I would like to start with pregnant women and children. From there, we'll go upwards. Member of GEMS, I'm a member of PARMED, Medical Aid Scheme. And it's one of the medical aid schemes which should not exist. And when I say so, they believe I'm talking politics. PARMED is a medical aid scheme that covers only 2 groups of individuals. It's a politician and a judge. Members of parliament, whether in Cape Town or in the various provinces, as long as you are a member of parliament, they are on PARMED. It's very highly subsidized scheme and the most expensive. Many of you believe Discovery is the most expensive medical aid scheme. No, PARMED is. But should we run systems like that? And what do I mean? I'm on PARMED. If I retire today, I'm going to pay only 20% of the premium, but still get all the benefits for the rest of my life until I die. That is something that is not available to an ordinary South African. Is that universal health coverage? No, it's not. It's not. Now, let me go back to James. In the NHI Act, if you read it carefully, we have never said we are going to do away with medical schemes. The war is not about that. The war is about the fact that we said medical schemes cannot pay what NHI is paying for. We can't duplicate. And people are fighting us for saying that. But that's already happening. There's no duplication now. And what am I talking about? We are giving immunization as the state. It's not being duplicated by a medical aid scheme. We are the only ones who are immunizing largely. The immunization paid for by medical aid scheme is very minuscule. Most of the childhood immunization is done by the state, and we are not forcing medical aid scheme to duplicate it. So if you duplicate services, healthcare is going to be very expensive in South Africa. That's all that we are saying. We never said we must do away with medical aid scheme. We just said there can't be duplication. If the Department of Health says we're going to put a package for all the pregnant women and pay from NHI fund and equally so, why should there be somebody duplicating it somewhere? The issue of increasing tax. There is an argument about Section 49 of the Act about increasing tax, which is done by the Minister of Finance. My own view is this. We've got enough money for healthcare in the country. We just divide it wrongly. That's my own view. I told you are already on 8.5% of the GDP. Many countries are not at that level. Many countries are at that level. So why should there be an increment of tax because of NHI? I personally believe we don't have to go that. If we go to that level, it will be very, very minuscule because we are duplicating a lot of things. I know of people who are on a medical aid who get involved in a car accident, get money from road accident fund, get paid for by a medical aid, and attend the public hospital and say they've got no money. All those monies are being paid for. They come from the sources of the same country. Yes. Do you know the amount of money that is there in road accident funds? It's a lot of money, but people go there to get the cash and bank it and come to public hospitals to still get health. Then there's medico-legal. We've paid lots of money for future medical care for medical aids. And I can give you a list of babies who we've paid millions for them, but they come back to the public healthcare system to be treated free of charge. So there's a lot of money for health in South Africa. It's just being distributed wrongly and being used wrongly. And for that reason, I don't really believe we are going to be forced to increase taxes for NHI, as people are saying. It's scaremongering. That is clear scaremongering. The NHI money must be ring-fenced. Yes, of course, it should be. But let me also bring something here. We, in NHI, we are trying to do what is called purchaser-provider split. In the private sector, you have got it. And that's why the private sector is so efficient. Why are you denying us to do it in the public sector? The purchaser-provider split, what is it? Private hospitals like the Clinix group is a provider of healthcare. The purchaser are the medical aids. Dr. Kinosi, I know that you are the chairperson, and my former university classmate there, your CEO, Dr. Matseke, and everybody else, you are providing healthcare. If you start providing substandard healthcare, the purchasers who are medical aids will not encourage their people to come to you. They will never. And people won't like, they will tell their medical aid, no, I can't go to clinics, groups of hospitals because they are providing substandard care. Because the person who's providing and who's purchasing are two different people and they must satisfy each other. It's not like that in the public healthcare system. MECs are providers and purchasers at the same time because they are given the budget. If they provide substandard care, the government still pays for it. No matter how substandard it is, we still pay for it. Even tomorrow, if you go to any public hospital, which is run in any particular province in the country, and found the standard very low, that is still going to be paid for by the state because there's no purchaser-provider split. So that money, yes, is going to be ring-fenced and be used as purchaser-provider split. Now, the certificate of need. Every country, or let me say most countries, have got a certificate of need. That there was an argument in court. That's why we appealed. That we are going to uproot GPs and move them around the country and all that. I don't know if the act says that. That was not the aim. If that is what is in the act, we'll be very much prepared to change it. All we want is the certificate of need, is that we need to know where doctors are, where are they practicing, and how are they doing. At the moment, nobody knows. There's nobody, not the Board of Healthcare Funders, not the Health Professions Council, not SAMA, not maybe SAMA, not us. We don't know where doctors are practicing. All that we know is that they were given a certificate, they've got practice numbers, we don't know what they are practicing, what they are doing to the patient. We don't know the quality. We don't know anything about that. But we know that doctors are practicing, and we can't go on like that. Even petrol stations are not established anywhere in the country. There's a certificate of need. It goes according to the needs. Dr. Pindile, the OHS inspection, I'm laughing because the person who's responsible is the one you asked the question to, is Dr. Kinosi, is the chairperson. He must explain to you. But on my side, I'll explain why we established the Office of OHS. Because I told you that we are modeling more or less, even if countries are never identical, I repeat that. But our model, we are learning from the British because we are using their system already. Back then in 2010, we invited Lord Nigel Crisp, who was in the House of Lords then. That's why he had the title of Lord. He was once the CEO of the NHS. We invited him to come to South Africa and workshop us. And during the workshop, he said, this system you are establishing, it needs to be protected from various problems that will emerge. And one of them is the issue of quality. And they said in Britain, we have got a Quality Care Commission, a commission that deals with quality. So we thought we needed to establish a Quality Care Commission in South Africa, but we called it OHS, Office of Health Standard Compliance. We did not want to copy the word Quality Care Commission, but it's to guarantee quality, not to punish people, to make sure that people put a particular quality, because if not, everybody will practice whatever they want. And that's why we established the Office of Health Standard Compliance. The second thing, the Office of the Health Ombudsman, which is now in the Office of Health Standard Compliance. I was arguing at that time, we have got the public protector. When people have got problems with the state, they go to the public protector. Who is protecting health? And so we established the Office of the Ombudsman in the Office of Health Standard Compliance to make sure that people are forced or encouraged to give good quality health care. Because if we don't do that, they will just do it in whichever way they want. The aim of the office was not to close practices, but please, colleagues, if you open your practice, your GP practice next to a shebeen, where it's smelling and people are drunk and all that, what are you thinking about your patients? What should we say to you about that? Should you just leave you and say it's a free country's democracy? Surely you don't expect us to do that. But the OHC is not for there to close places, but to insist. For instance, in hospitals, if we don't have Office of Health Standard Compliance to go and inspect hospitals, a lot of things will go wrong for the population. You'll find a hospital where somebody is practicing and giving people injections of penicillin, maybe I'm outdated, without there being adrenaline or anthysen or all that. I've seen such situations, meaning you are planning to kill somebody. So we can't allow those type of situations. That's why we need inspections. Thank you very much.
To close the loop, I think you quite appropriately referred to the establishment of the NHI fund, after which then you said, I think quite appropriately also, that we'll start at the beginning of life with the pregnant women and of course newborn babies. But how far are we insofar as the establishment of the NHI fund is concerned? And to what extent are what we hear in the media about court cases, against the NHI implementation. To what extent is this affecting the progress of what the minister and the rest of the health department and related entities are trying to do?
Okay, maybe in that regard, I don't have to wait for the other questions because this is very important. We have got 9 court cases, 9, because people wait for whatever statement we make, they rush to court and say, I heard minister saying this, I heard him saying that. Even things that are not new, they open a new court case. We went to court and say to the Pretoria High Court, all these cases are challenging one thing, which is NHI. Why can't they be consolidated into one? It's one case brought by different people, but challenging the same thing. And we are worried that it's not going to end. We're going to work to be in court for the next 10, 15 years. And so it's not in anybody's interest. So we said consolidate them. But some of the people who went to court opposed us. They rejected consolidation. They say they want to go one by one as different entities. So the judge then said they are going to put a hearing, meaning a case within a case, whereby on the 26th of February, that's next month, there's going to be a hearing about whether the cases ought to be consolidated or we hear by them one by one. If we hear them one by one, it's going to be a very sad day for South Africa because we'll be in court for the next 15 years or so. But on the issue of where we are with progress, I've got Professor Crisp. He's here. I think he has logged in. I brought him in specifically because those are technicalities which I don't want to entangle myself in. I think he can give you more or less where we are with the situation. Remember, the president signed the NHI into an act only in May 2024. May 2024, that's about 18 months ago. Once the president assent to an act, we issue regulations for public participation. It's a long process. No act can be implemented without regulations. So we are somewhere around there, and Professor Crisp will explain. If you allow him, please, Dr. Ramatisela and Dr. Ginosi, can you allow Crisp? I'm giving that to him.
Thank you very much, Minister. By all means, we will allow Professor Crisp to respond as you have ordered.
Okay, good evening. Thank you very much to everybody. I'll say protocols observed. I'm not able to unmute or show my video, but I am here. So we have been preparing a whole range of the technical details of what's in the NHI Act. I've been reading all the comments that have been made, and it's clear that very few people who have commented have even read the Act or even understand what the NHI is about. So we have a lot of work to do. But the preparation that we've been doing is making sure that we define exactly how we are going to register users. That system is in place. What exactly a user will have to bring with them, how they will do that registration, how the data is stored. So we have about 35 million people that are already registered on the NHI, and that we know the system is working. The second one is around enrollment, where the enrollment process with general practitioners has to be captured so that the GPs can be paid on their capitation payments. We have a memorandum of understanding with the UFFP, the Unity Forum for Family Practitioners. We're working very closely with them and others on exactly how that enrollment process will work. On accreditation, we've done a lot of preparatory work on exactly what the accreditation process will look like and how the steps will unfold to make sure, particularly in the primary healthcare space, people will be able to be accredited, including if they do not get certification with the Office of Health Standards Compliance, because we know that's going to take time. Then in terms of what the Minister was saying, the regulations, we did prepare regulations. They were published in the Gazette. There were many comments as a result of that. And the legal advice that we've been having, we will go out with a new process, which we've been preparing with the presidency. And we have been observing some of the comments that have been coming around the court cases to make sure that we don't have to take another step back on that process. There is also the Office of Products Procurement, which started off, we buy billions of rands worth of medicines in that office at the moment. We get very good prices for it, and that's one very big national procurement process. We are starting to get our heads around the procurement of other health products, in other words, medical devices and diagnostics, and that is all coming together very well. Then on the digital systems, the minister spoke about the CSIR. We are very happy that the digital systems will be ready when we start to roll out. We have 9 contracting units for primary healthcare in the primary healthcare space, where we are testing all of these systems in what we call a horizontal manner. In other words, not just vertical or piloted projects, but as a horizontal service. So many of these are coming into place. And then, of course, in the department, as the minister alluded, there's a lot of work that's been going on upgrading of infrastructure. We don't have nearly the budget that we want, but we are engaging with National Treasury on both new facilities and upgrading of facilities. There's been a lot of interaction with National Treasury around the human resources issues, because we know that we don't have the budget to employ all the health professionals that we would like to employ. And then there are activities that are going on with the private sector, which we've been doing with the Competition Commission and the Department of Trade and Industry to regulate prices in the private space, but that's still got a way to go. So those are just a handful of some of the issues that are under evolution at the moment. And as the minister said, NHI implementation is not an event. It's a journey, and quite a lot of those steps have already been taken. I think I'll leave it at that. Thank you.
It's amazing the amount of work that has been going on, almost undetected, if I wish. One thing I would like to say is that we need to ensure that this type of information gets out there, because a lot of progress has obviously been made in all the preparatory work for the implementation of the NHI, or in fact that the NHI is already being implemented in many respects. And the work that has gone into this is quite amazing. And I would like to encourage the department to publicize this a little bit more, because I think even among healthcare professionals, there's a lot of ignorance around some of these issues. Just before I take a question from Vanilla Govender, now that you spoke about human resources, can you just in a few words explain the future of RWOPs in view of the National Health Insurance and the Universal Health Coverage, remunerative work outside the public service, which is quite a practice in South Africa to a large extent?
Minister, I'm sure you'd like to respond to that one.
Yeah. That one is mine. Colleagues, back in 1994, immediately after the democratic elections, the trade union movement COSATU, which was huge at that time before it split into several factions, the trade union COSATU approached the state and complained that the government is not paying very well. For that reason, they were not talking about health workers, they were talking about public servants. For that reason, they are asking that the state allow public servants to go and augment their salaries outside the state. And that must be given to everybody who's a public servant. At that time, it was true. For instance, a professor at a university, even a professor of medicine at a university, was earning far less than a chief director in government. You are aware that the titles in government is, we start with the director general, which is level 16, followed by a deputy director general, is post level 15, followed by a chief director, which is 14, followed by a director, which is 13, and goes down like that. But we found that professors of medicine were much less than level 14, which is chief director. So we found that at that time, when you advertise a job in government, even professors leave their universities or teaching hospitals to go and apply to be in the state. That was not a healthy state of affairs. So the government agreed to give RWAPs. RWAPs means R, remunerative work, O, outside, W, work outside the public, the what you call, remunerative work rather, RWOP. humanity work outside the public service. That's what RWAPS means. And it was given to everybody. For some reason that I still could not explain very well, maybe one of you can explain, it took root among doctors and nurses, not any other public servant. And I'm repeating, RWAPS was made available as a policy of state to allow those who can to augment their salaries outside the state. But it took root among doctors in a way unimaginable. Doctors to RWAPS, nurses to moonlighting. And both of them are destroying the healthcare system, particularly the public healthcare system. But I can assure you, they are also destroying the private healthcare system. In what way? Many professors and many specialist consultants are not at their places of work when students need to be trained. They are not there. And some of the trainees will go into private sector. There are already complaints that were even producing specialists that are not ready for the job because they had nobody to train them. Some years back, before we opened the medical school at the University of Limpopo, which was still called University of the North, Medunsa, that's the Fako Mahat, which when it was still called Medunsa, we're sending students to Mangweng Hospital, which is next to the University of Limpopo now. And we had to send senior lecturers and professors there to take care of them. One day, I was still it was still my first month in health. When I went there, I was in health for the first time. The CEO of Polokwane Medical Clinic at that time phoned me and asked me, Minister, I understand that you have sent students to Mangweng Hospital to be trained by specialists who you have also sent there. I said, yes, sir. He said, when do they do the training? I said, what do you mean? He said, they are always here at Mediclinic asking for theater time, doing their own operations here. And how are those students going to, those students that are at Mangweng, who's going to train them? So I'm just giving you an example. I'm staying here in Swani. They will tell you that if you go to Louis Pasteur Hospital any day in the morning, you'll find surgeons there who are supposed to be training students and specialists and who are supposed to be mentoring young doctors. You'll find them there. Now, are doctors still earning less? And the answer is no, and a big no. At the time, the government allowed to give RWAPs, where I said the professor was earning less than a chief director. There was no OSD. Minister Trevor Manuel in 2007 then introduced OSD, occupation-specific dispensation, which pays so much money that as I'm speaking to you now, many senior doctors will never accept a job as a CEO of hospital. That's why our public hospitals are not doing well. Because go there and check who are our CEOs. They are very junior people, especially nurses whose OSD doesn't pay as much as that of doctors. Any doctor, especially those who are at high level, who are specialists, they will never take a job as a CEO because OSD pays them monies they've never seen before. So should we be keeping RWAPs under those conditions? So I said, I can't take that decision. It might be unilateral, it might not be scientific. I then put up a team which was chaired by the former Director General in the presidency, Dr. Cassius Lobisi, deputized by Professor Somado Dafigeni, the chairperson of the Public Service Commission. I put quite a number of specialists there, including the CEO of the College of Medicine, Dr. Eric Buch, who was once an HOD in Gauteng, and of course a dean of, who was once a dean of medical school in Pretoria. So they've got experience. There are 15 of them. I put them and say, go out and consult people about these RWAPs, whether we need to go on this way. Should you, for instance, as a head of department, be leaving your students and going to do RWAPs? Can a principal at school leave their learners with their teachers and go elsewhere to augment their salaries? Should we continue that? I want those questions to be answered by this team, be given to me. I'm prepared to take them even to Parliament or to the National Health Council, which is a statutory body, to take a decision. If they say no, leave things as they are, of course, there's nothing I can do. But I want RWAPs to be reviewed. Not only RWAPs, we are reviewing 2 other HR policies. The second one is committed overtime. What is committed overtime? Committed overtime was established at the time when there were so few doctors in the country, that we believe every doctor must be forced to do overtime, whether they like it or not, and such that it must be put in their salaries. And many of you will be shocked when I say we used to have so few doctors. They will say, but there are still few colleagues. Before I went into Home Affairs, to be a doctor was what is called a scarce skill in terms of the rules in Home Affairs. Scarce skills are skills that are needed by society, but are found in, such people are found in small numbers in the public. The Minister of Home Affairs must publish a list and gazette it of scarce skills. We have removed doctors from that. I mean, I'm talking about MBCHB. Omni specialists are a rare skill. I mean, scarce skill, not rare skill, scarce skill. Ordinary MBCHB like myself, we not. In nursing, we did the same thing. Only 4 specialist nurses are a rare skill. The rest, we've removed them from the scarce skill list. We have put only theater nurses, an ICU nurse, psychiatric nurse, and a high care nurse. Those are scarce skills that we've put there. So should we still regard committed overtime as if to be there when we had such few doctors? The third one was rural allowance, where we're saying people go to rural areas where there's no TV, there's no TARU, there's no that. Should we be keeping that? Education has done away with it, by the way. There used to be rural allowance in education. It's no longer there. Why should health keep it? It's also being reviewed. And the last one, community service, which is now a statutory, which is now statutory. Community service was established when doctors were refusing to go to rural areas because they had options, they could go anywhere. And so it was established such that each and every hospital must have at least 1 doctor, just 1. I mean, sorry, must have a doctor at least for that year. And when he leaves, another 1 comes in, etc. But should we still run the country like that? Lastly, I was told by the Public Service Commission that any policy that will live for more than 15 years is likely not to be serving its intended purpose. And most of these policies that I said we must review have been there for 30 years. So it's time to review them. Thank you, Dr. Ramachisen.
The mouthful, Minister. I'm not going to say anything more. We have a question from Vanilla. I think I'm pronouncing it correctly. Governor. Can you unmute Vanilla and as briefly as possible put through your question? Vanilla? Do you still have your Vanilla? Oh, he Dr. Kinosha, I'll hand over to you. You still have a comment to make. The minister make reference to your association with the OHSC. So please respond to that. And
you can give us one last round of questions that you recorded from this.
Yeah, thank you very much. I think can read that. Okay, thank you very much, Minister. Yes, I'm still associated with the OHSC Office of Health Standards Compliance as the chairperson of the board. This will be my last year there, but it has been nice being there. I think this is a very important question because it has been asked many times, especially by general practitioners, but also by specialists in the private healthcare sector. And I think, and it's a lack, it's lack of understanding, I think, and maybe we have not, as a country, explained it enough that for any practice to or hospital or practice, whether GP or specialist, to register with the NHI fund, so that just like you register with medical aid schemes, NHI fund will be will pay their funders. They'll be paying professionals, health professionals, who claim after they've provided a service. Now, for you to be able to be accredited by national by the fund, you will have to have a certificate. You'll have two things. First of all, you have to, if you go to section 39 of the NHI Act, NHI Act number 20 of 2023, it is in your pocket, actually. You don't have to go and search anywhere. It's in your smartphone. If you Google National Department of Health, you Google for NHI Act 20 of 2023, section 39, it explains everything, how to be accredited by the NHI fund, so that you can submit your claims after you've seen a patient who's come to your practice with your NHI card. One provision is that you must produce registration with the statutory body with which you are registered. If you are a doctor, for instance, HPCSA, if you are a nurse, SANC, or if you are a pharmacist, Pharmacy Council, so you must produce the fact that you are registered. But secondly, you must produce a certificate from the Office of Health Standards Compliance, which say that your practice complies with quality health standards. And these quality health standards are set by National Department of Health, but OHSC makes sure that you are providing the quality of healthcare that is acceptable. And I think, as you can understand, we need to make sure as a country to make sure that our patients receive quality care, high standard quality care. And that you are now, because the person who asked the question asked about the tools used. There must be tools, obviously, so that assessing your practice is done in an unbiased manner. So there are standards, there are tools that are used. They're not very restrictive. In other words, no practice will be closed without prior information to you that you need to correct this, you need to correct that. So the inspectors from OHSC will come to your practice, tell you what you need to do with to receive certification, so that you can be registered with the NHI fund, so that your claims can be paid. And I think it's a quality measure. I think the minister has spoken a lot about quality provision in the country. I'll just go to 3 questions. There are a lot of questions. There are 137 other comments and questions. So we won't be able to go through all of them because of time, Minister. And I think Minister, unless if Minister wants to take a few more, but I've got 3 that I will share with the Minister for maybe to respond. The rest of the questions, we will go through them. They are in the chat. We will go through them, sift them, and then those that we think are not just comments, are questions that need to be put to the department. We will send them to the Office of the Minister or to the Office of Professor Nicholas Crisp to register or to comment on. I think Professor Crisp, who's on the line in the House today, has already said that he is looking at the questions. So we apologize because of time. We can't go through 138 additional questions. But let's, Minister, just three questions that I think are the ones that maybe Minister can look at. Billing. I think there's a question that says billing proposed for healthcare providers. How will healthcare providers bill? Will there be a standardized rates, consultation tariffs, for instance? How will tariff determination happen? Maybe either you or Professor Crisp can answer that. Payment of healthcare providers under the NHI fund. The next question is from someone who says that, who talks about the standard healthcare management, and they are talking particularly about the Free State. Sorry to those who come from Free State. The quality of healthcare management in the Free State, or in healthcare, in public healthcare. What are we going to do about it? That's one other question. I think the last one, let me read it out. It's from Mohomutsi Molekwa, who says, what does the NHI mean for us as private healthcare workers? Will we still be able to work in any area which we choose to work in, I suppose? Or will there be limits set for the amount of healthcare workers per district? Will we be forced to work in rural areas? How will you ensure the rural areas have sufficient numbers of healthcare workers, including specialists? So it's a multifaceted question, but I think it's about the uncertainty of whether NHI will come with determining where people should work and should not, and also the patient population per healthcare worker. How will that be determined, and so on, especially in the primary healthcare, I suppose. But he's also asking about special resources in the rural healthcare. Maybe I'll stop there for now, Dr. Ramathisela.
Okay,
Thank you very much, Dr. Kinoshi. Let's allow the minister to briefly respond to the questions that you've asked before we pass the vote of thanks.
Yeah.
Minister.
Okay, thank you. I just want to free you, Dr. Ramathisela and Dr. Kinoshi, that I'm in your hands. If you say this, we don't have time, it shouldn't be because of me. I'm here for you. If you say now we stop or we continue, I'm here. I'm in your hands. I'm really controlled by you. So take a decision, not based on my wishes, but based on what you think should happen. I just wanted to clarify that. The issue of standard of care, especially in rural areas, not on, I mean public hospitals, not only in the Free State. That's why we are establishing an office. That's why we have to. Some public health care institutions improve because of that. But, you are aware that is the nature of human beings, to do wrong things. And if we don't have an office that deals with that, we are going to regret. I once visited a hospital where a lady in the ICU, small, very rural hospital, and the ICU was almost empty with resources. And she said, no, we have just passed the inspection by Office of Health Standard Compliance. I said, no, they must have done something terribly wrong. There's no way you can pass when you have got such few resources. I'm going to visit the office and ask them why they passed you. And she said, no, it's because we went to borrow this equipment from other hospitals for the inspection. And I nearly fainted, because public servants sometimes do that. I nearly fainted because I was once an MEC for Education in Limpopo. Minister Naledi Pandor was the Minister of Education. She came to Limpopo because we were visiting one school together. And when we arrived there, I found brand new desks. And I was very impressed. Very good new desks, clean schools, etc. When we leave, one old man accompanied me to the gate and said, MEC, I was the MEC at that time. He said, but we also want new desks like this, man. They look very good, our children will pass. I said, but we have got this desk. What do you mean you are looking for desks like this? He said, these ones, we borrowed them from other school for your visit. When you leave, we're going to take them back. And I said, oh my God. Now hospitals are doing exactly that. They've got nothing in the ICU or in a place they call the ICU, and they say the office is coming. We're going to borrow equipment. So one of the things I'm going to do, Dr. Kinoshi, I haven't yet raised that with you. I think we must do unannounced visits. We must do unannounced visits. Because if we keep on announcing and telling people and they behaving like this, because that hospital, I tell them, but you are disadvantaging yourself and patients. And that school, I told them, you are disadvantaging school kids to impress me and Minister Naledi Pando. So we all know exactly what is that which you need. But people behave like that because they don't want to be seen to be failures and all that and all that. So the standards of healthcare, we have got to have an office that is established to make sure that's a standard. The issue of Dr. Moromotsi Moleko, I heard this many times that doctors are no longer going to do what they want. They are going to be employed by the state. No. The aim of NHI is not to abolish certain professions and doctors. All we are saying is the public ought to have access to every doctor in the country. At the moment, they only have access to a doctor if he's working in the public service. In the private healthcare, no. And 80% of specialists are in private healthcare. There is a hospital. It's not a Clinix group of hospitals, but there is a hospital, I'm not going to give its name, in the center of Johannesburg. They've got 57 gynecologists. Is that wrong? No. But what is the problem? Because Limpopo as a province, Mpumalanga as a province, Northwest as a province, all three of them added together do not have 57 gynecologists. They don't have them. But we have got them in one institution. Should we continue like that? Are we going to take those doctors and force them to go to Mpumalanga? No. But we must find a way for people from there to get access to them. Surely that's the right way to use resources in a particular country. So we are not going to say doctors must no longer run their practices, but we want to work with them in such a way that the public must have access to them when they need them. Honestly, look at mental health now. Look at mental health care. Mental health care is on the rampage. And this country called South Africa, with 63 million people, have no more than 800 psychiatrists. In fact, I think it's 750. But 80% of them are in the private sector taking care of 14% of the population. What's going to happen to the rest of the population? The 86% of the population? Surely they are also entitled to a psychiatrist in one form or the other. So those are the things that really need reform. The issue of billing for healthcare, I think Professor Crisp can answer that. But before he answers it, at the moment, most of the GPs in the country are running fee-for-service system. I want to inform you that the final report from the Health Market Inquiry, chaired by former Chief Justice Mmobo, has clearly recommended that we must abolish cash as a method of paying for health care. They said no country will go anywhere near reaching universal health coverage if we keep on making cash as a method of payment. We must find other methods of payment. That we have not yet implemented, we are still working on it. But I'll allow Professor Crisp to explain this issue of billing. Prof? Professor Crisp, is he gone?
The last I checked, it was still available. Has he been unmuted? Professor Crisp? Professor Crisp?
Yeah, thanks very much. Oh, you wouldn't, I was blocked from unmuting. Thank you very much.
Sorry about that.
Yes, indeed. So the Act provides for a range of different forms of payment. So what the minister has said is that globally we know that the most inefficient form of payment is fee-for-service. It has huge perverse incentives attached to it, and it drives suppliers-induced demand. So we are advised everywhere around the world, people are moving away from fee-for-service. There are some circumstances in the health system where it's unavoidable and we will have to use fee-for-service. But in the primary healthcare space, the National Health Insurance Act provides that we will pay capitation. And that is what I mentioned when I answered a previous question, that we are working with the Unity Forum for Family Practitioners and others to agree on what is the benefits package that will be covered and which GPs should provide. And in fact, we talk about multidisciplinary teams, and we're talking with a wider group of people on how to phase in those multidisciplinary teams. So the idea in capitation is that a practice is paid for the portion of the population that is enrolled with that practice, and then they look after that practice. And the way in which our current thinking is, and our current design has been costed, is that it's a three-part capitation. The first part is just for the number of people. The second part is risk adjusted, initially on age and sex, because we know that we weight the participation of patients in primary healthcare based on mostly on age and sex. But we will add epidemiological factors afterwards once we are confident that they are reliable data. And then there's a performance portion. And what happens in the contracting with the GP is that the GPs agree with the fund on certain targets that they will meet within that community. For instance, bringing down diabetes, bringing down hypertension, and so on. And there are targets over 12-month periods and longer where larger bonuses are paid for improving healthcare. So that's in the primary healthcare space. In the hospital space, the preferred method is diagnosis-related groups. They will take us some time to put in place, and we've been learning from the former Soviet states that they have taken anything from 25 years and more to build their diagnosis-related groups. Australia also took about 20 years. So we will start with small numbers of groups and phase them in before we start trying to get too sophisticated. And then there is a broader set of what they call capped case-based fees, which are mostly used in emergency medical services. And there are also global budgeting opportunities where, when you don't have the data, you allocate the budget based on a global budget, but not on the way that the current public budgeting works. So there are different mechanisms, and one uses the blending of those mechanisms to make sure that you are paying fairly. There was a question asked about the choice of work, and are we going to be forced to work in different places? The answer is no, you don't get forced. You follow the money. Everybody follows the money. The minister always tells us in the department, people follow the money. So what money do you follow? Well, the fund's primary function is to drive equity. And if there's too little money that's going into payments of services in rural areas, the fund has to allocate more money to that area. So you will see that because there's an amount allocated per capita, that there's better opportunities for particularly primary healthcare providers, and that doesn't only mean GPs. There are many nurses, physios, OTs, and a whole range of other rehabilitation workers who primarily work in the primary healthcare space. And they will find that there's more money to be made working amongst communities which have previously been disadvantaged. But I'll leave it at there for now, and maybe we can organize a separate webinar where we can go into these details with some of the experts. Thank you.
We sure do. I think we've run out of time, and I take this opportunity to thank you and Minister, as well as Professor Crisp, for extending us, and we still have more than 1,000 participants on the webinar. Just one final question I would have done it in ask this. It's two-pronged. Minister, in your address of the Universal Health Coverage Day on the 12th of December last year, 2025, you made reference to a policy shift that has been introduced that is going to see a phased redirection of 34 billion from the medical scheme tax credit towards the NHI fund. If you can just give us a little bit of detail around exactly how this is going to work and what impact it's going to have. And of course, finally, reference has been made to POLMED, GEMS, and PARMED
as schemes that are looking primarily after government employees. But what is the future of medical schemes in the bigger scheme of things? And at what point are we going to see a specific shift in that area in the implementation process of the NHI?
Let me go to the last question about the future of medical aid schemes. I told you clear that some should not exist. Hello? Can you hear me?
Minister, can you unmute?
I'm unmuted. I'm unmuted.
Can the Minister unmute and respond?
I am unmuted, Doctor.
Okay.
I'm unmuted. Can you see me?
Now we can see you. Now we can hear you. Please respond.
Yes, I've been unmuted. Yeah.
Thank you.
Yes, I am saying I'll start with your last question about the future of medical aid schemes. We have got 71 medical aid schemes in South Africa with 313 options, if I'm not mistaken. 311 or 313 options, all of them to be administered. And the amount of money, and with trustees and all that, is 28 billion rand just going there to manage the medical aid scheme, the money that we should be using in the healthcare system. Now, there are certain medical aid schemes that should not exist. And I've mentioned PAMED, to which I belong. And I told you it's a medical scheme for members of parliament and judges only. Why should it be? And it gives huge benefits which nobody else can get. And why am I so sure that PAMED should not exist? Because let's go back to why it was established. We had old men who spent half of their life in jail, Nelson Mandela and his cohorts. But we also have people who were getting out of the system, FW de Klerk rather, and his cohorts. So they were given a medical scheme called PAMED so that they can go and retire in peace. Most of them is 30 years now, most of them are gone, but we are still keeping a medical aid scheme that was established to smoothen a transition, and a medical aid scheme that is so expensive. And lastly, there are no more than 5,000 members of PAMED now. Insurance is about numbers. The more people you have got, the less expensive it becomes. But if you have got an insurance with very few numbers, the premium will going to be high, and they start cutting the benefits. That's what is happening in some medical aid scheme. PAMED is for police only when we have got GEMS. Why should public servants belong to GEMS and others like police go to PAMED? And I know they were trying to rebel and fight that we should not abolish their medical scheme. Now, when you listen to Madlanga Commission, you see why police were fighting. They used to fight me and rebel and threaten that they won't be part of NHI. Because under NHI, there are going to be no cat matalas. They will never be cat matalas. And very clearly, police thought, no, they are going to lose and say, no, NHI, we don't want it and all that. So we have got many types of public servants, a judge and a politician, PAMED, a policeman and police officers, PAMED, the others, GEMS. And all of them need to be managed. They need to have trustees and all that. That's a waste of money. So that's where we are going to look first. The other medical schemes I told you, especially the private ones, the open ones, we just simply saying they are not going to duplicate what is being paid for. But the time for us to arrive there, it's not going to be less than 15 years. I want to be open to you. That means at the time at which we say we are ready now, we've gone so far in implementation that medical aids can no longer duplicate. It won't take us less than 15 years. That's the practicality of this whole process. And many people will just believe it will happen tomorrow. No country has been able to do that, Dr. Ramatisela. No country has been able to do that. The first part of your question, if you might remind me, you said it's about what I said on Universal Health Coverage Day. I was targeting tax credits for which some people rush to court immediately. It is on Section 49 of the NHI Act. I was just explaining what it says. Professor Crisp and me were called to Parliament by the Committee on Appropriations, which is headed by Musi Maimane, to understand Section 49. As he was explaining what Section 49 means, some people rush to court and believe we are introducing a new policy. It was not new. We were talking about how NHI is going to be financed, and part of the money we believe is tax credits. And why do we believe it's wrong? How did tax credits come about? We inherited them from the previous government, from the apartheid government, which wrongly thought, and I insist it was a wrong thinking, that if the state encourages people to join medical aids and incentivize them with tax credits, if the state encourages people to join medical aids and incentivize them by giving them tax credits, many people will go in that direction. And when they are sick, they won't trouble the state. They'll see to finish. More or less like the prodigal son in the Bible, who said the father must give him everything and he's going to go away, and the father will take care of the other kids. You know, it never happened that way. He came back immediately. Here we are giving people heavy tax credits to move away from the state. They don't move away. Many of them by July, they come back. Their benefits are finished. They come back to the state. Some of them are still in coma. They get expelled from ICUs and come back to the state. So why can't that money for tax credits? And there is a fight when I mention tax credits. But when they are mentioned by other people, nobody is fighting. When the government of national unity started, the Democratic Alliance under Mr. Steenhuisen told the president that no, they are against NHI, but they've got alternatives. The president asked them to put those alternatives in writing and bring them to us. And they wrote 6 alternatives. One of them was that any human being who earns more than 800,000 rand should not be getting tax credits. Because even the president himself asked me, he said, but minister, if I'm asked, why am I the president of the country and I'm so heavily subsidized, I get tax credits, I get subsidy, how do I answer? I said, President, that's the scandal of our times. Even members of parliament, I asked them the same question because they belong to Parliament and they are very heavily subsidized. I asked them when Julius Malema called for a debate in Parliament about Donald Trump when he took away 7.8 billion from PEPFAR. The money we lost from PEPFAR, 7.8 billion. And South Africa is spending 750 billion on health. But we cry when one man takes 7.8 billion away. I asked them, I said, Honorable Malema, can you look inward? Why should all these honorable members be so heavily subsidized? But we go to chase Donald Trump and say he must give us money. When we ourselves cannot help our own people, we subsidize ourselves. And we run to Donald Trump and chase him and say, no, he's evil, he took our money and all that. No, it can't be. And they all ran away from it because now it's touching their pockets. But even when I arrived with Mr. Maimane, we told him the same thing with the professor and saying, Mr. Maimane, you are being highly subsidized. And he said, guys, it looks like we have got a very good policy, but we are not able to inform the people about it. And so, yes, Dr. Ramatisela, we have lost the aerial battle in NHI because earlier on you said we have done a lot, we can't publicize it. Believe you me, we have told this to many newspapers many times. We issue statements, they can't because their narrative is that NHI must die. And we know they've taken such a decision. But they are powerful. The aerial battle, they are very strong there. We have lost it. We are trying our best. but I can assure you, there is no moral, moral probity in people who are well-to-do being so heavily subsidized by the state at the expense of ordinary people. One of the things that people took us to court are mentioning behind our backs, but sometimes they tell us in our eyes. They said, this minister is stupid. You are going to go to ask judges to make a ruling that will take their benefits away. They say because judges are members of parliament and they get so much benefits, so many benefits from parliament, they are going to rule against us because they want to continue those benefits. I'm waiting to see if our judges are moral or still have any morality left. That because we are benefiting, we are getting so much. I mean, I'm repeating, guys. How do I feel that I am working as a minister? And if I retire after so many years, I pay 20% of the premium I'm paying for permit, but still get all the benefits. And every politician is going to get that. What morality is that in our country? And yet we talk about universal health coverage, which must cover the poor. Surely these things must change. And that's what I said that day, Dr. Ramati said, that I don't see why we must continue with that credit. And when it was said by Minister Steenhuisen, nobody complained about it. But when it's said by me, it's communism. During the 2% VAT, political parties that were fighting against VAT even made the proposal that why don't you take money from tax credits? Because there's no need for us to continue with tax credits for the rich. Why don't you take that money and augment so that you don't make people pay VAT? That proposal was made by other political parties other than me. But when the word comes from my mouth, they say it's communism, we're destroying the middle class. That's what the Minister of Finance said. And I went to tell him, the destruction of the middle class is the amount they've got to pay for their health care. The ever-escalating amounts of health care, which even people who are rich can no longer afford. That is the attack on the middle class, not the stopping of the tax credit for those who are well-to-do. Thank you very much.
From a minister who has recently undergone eye surgery, I think, at St. John's Hospital here in Johannesburg. I think, Minister, you walk the path and you set the tone and the example on how public service should relate to public facilities. But I take this opportunity to thank you very much, you and your team, for today's questions. I think we'll bring it to the end, but just before that, I will now allow the Chief Medical Officer of the Clinix Group, Dr. Burton Shinas, to pass a vote of thanks. Over to you, Dr. Shinas.
Thank you, Dr. Motsoaledi. Minister, as always, listening to you and the passion with which you speak and the absolute conviction. It is always enlightening and it's encouraging. And thank you so much also for looking inward and looking at yourself and looking at the country, the ministers, the leaders of our society, and also saying that we could do better as leaders within the healthcare industry. So, colleagues, good evening. Once again, guests and friends that have joined us here today. So, as we draw this rather informative and insightful presentation to close, it really is an honor and a privilege to be able to extend our appreciation to the Honorable Minister, all the attendees, and also to the weekly organizers of the Clinix webinars. Esteemed Minister, I really need to say that South Africa continues to navigate, the rather complex and intricate within our society that are quite unique to South Africans. And you've been steering, you've been driving and guiding us on this journey for what seems like countless years now. Your presence this evening affirms your commitment to ensuring a health system that is defined by excellence, equity, and humanity. And you highlighted it on so many aspects during the presentation that you gave to us today. So we really want to thank you, Honorable Minister, for always availing yourself to extend and to share this message and to make it clear on such platforms. And then to our attendees, many of you are custodians of our health system, and you ensure that dignity is provided to all South Africans. So we want to thank you not only for attending this evening, but also appreciate your tireless efforts in shaping the future of healthcare in our country. You know, in the background, we have employees of the Clinix Health Group, and they, from the IT side as well as the marketing sections, they've really been working quite hard to ensure that this, even all its complexities in terms of logistics, that it runs quite smoothly. And we wish to thank all of them for putting this all together. And then obviously to our colleagues and the rest of the Clinix Health Group for the past 4 years, ensuring that we have professional and dynamic content each week. And while we were having the presentations, we noted that quite a number of attendees requested to be part of the distribution list for people that were wanting to be invited on a weekly basis for the webinars. So what we're going to be doing is sending a survey to all attendees to thank you for your participation this evening. And then there will be a question within the survey which will ask you to subscribe. It's more a click. And once you click that button, you will automatically be receiving invitations on a weekly basis. You'll also be invited to present on this platform on a weekly basis, which is normally held on Thursdays. So you will be receiving that invitation soon. But just once more to each of you who took the time to be with us tonight. Dr. Ramathisele, I know you're still recovering from illness. Thank you for taking the time out. And Dr. Kinoshi, as always, thank you for a great host and for continuing to inspire us on this journey. Thank you very much to everyone. Good evening.
Thank you very much. Thank you very much. Good evening too. I'm still available.
Thank you, Minister.
Dr. Crisp is available. If you want any clarity or any more webinars, we are ready to come to you. Thank you.
Thank you.
Thank you very much for that, Minister.